Alrighty, good morning. Happy week 12. Woo! Only one clinical day this week. Woo! We get to spend the week together because you've got me for a Monday and Friday lecture. And just a reminder that clinical is Tuesday, not Wednesday. There are no students at Clínica de Salud this week. We're all put into other places. So you're either at the Ridge, MH, Vitas, or YMCA. I think that's right. So there would be no food bank on Wednesday either. And I will do a pre-conference for the YMCA. What time works for, I think that's what, Amanda and Emily? Like, I don't know if either one of you work or anytime this afternoon. Okay.
I'm free this afternoon or after lecture.
Okay. And then there won't be a Clínica de Salud pre-conference because there's no Clínica de Salud this week. And then the Ridge, I just want to touch base because I think we have 1 or 2 new people coming in. If 5 o'clock works, we can do that. Or if you guys want to do earlier in the afternoon, that's fine as well, but I'll plan on 5 and I'll put links out after the meeting. Oh, okay. So after class today, I'm going to stay on Zoom to go over hours because you guys were all asked to submit your hours for clinical by Tuesday, or at least you should have been. And so I actually just got updated numbers and it will make everybody happy. And so I want to go over the 46 and 47 hours and make sure that everybody's filling out their comportment tools correctly and everybody's comfortable and see where we need what we need to work on to get people where they need to be. Yes. And then I will do office hours after that. And then I can fit probably Amanda and Emily, you know, after in office hours or something like that. We can do that. What else? And then if anybody has questions about things, we can do that either at the break or probably at the end of class. If people have like parking lot or other questions about things, we can go there. What else do I want to tell you? I think that's it. Questions on that so far? No questions? Okay, cool. So let me go ahead and share my screen so that I can tell you what the plan for today is. You should see lesson week 12 on your screen. Somebody, anybody? I got Amanda right in front of me. So, okay, she's not. Okay, cool. So today we're going to talk about sensory perception in terms of vision and hearing, concentrating on that. And then we're also going to talk about cognition in terms of the exemplar is Alzheimer's. We're going to do cognition first, and then we'll move to the sensory perception. And so the readings are here. I didn't expect everybody to read. I apologize. I'm always late putting stuff up or opening up the module. So my apologies for that. The assessment chapters should be review from anatomy and physiology, focusing on, I have PowerPoints. I'll go over those today. And then also with the Alzheimer's. ATI nursing care of children has good information. It's a really good, it's just like summary, you know, because the reading it's so concise and it goes in has great headings and stuff. So I think that is a good thing. And then we'll do the cognition ones first, probably take a little break and then come back and do this sensory perception. Did anybody bring cotton balls? Because we're going to talk about that. We're going to kind of see what it's like to have vision and hearing impairments. And so the activity assignment that goes with the cognition piece is that here are examples of the mini cog, the mini mental sensory exam, and the St. Louis University mental, I can't remember what the S stands for, form. And so you have examples of those. In clinical this week, or with a family member or friend. If you don't have an appropriate clinical patient, what you're being asked to do is perform a mini cog. So let's take a quick look at the mini cog. Some of you may have already seen mini cog. If you've been at the Ridge with me, you've probably seen it, or you may have seen it other places. So this is a screening for dementia for cognition. It gives you exactly what you're supposed to do. The word recall, it even gives you words to use, which I think is great because I can never figure out which words I want to have them recall. And then it shows you how to do the scoring. So you can't, and then it gives you a page for them to draw the clock. Although I think it's better to hand them a blank piece of paper and have them draw the circle, because I think that gives you more information as well. So you can do that on a patient, like I said. You can do it on a family member or a friend. No worries on that. And then what you're going to do is, so that's going to be your baseline. The mini cog is going to be your baseline. And then you have your option of doing a second screening, because we're going to compare and contrast, kind of like when we did the fall risk assignment, comparing the fall risk and the ADL assignments. Which one do you like better? Which is easier to administer? You know, that kind of thing. So this is the mini mental state exam, the MMSE. And so it again tells you, you know, you ask them, what year is it? Do you know what season it is? What's the date, day, month? Those kind of questions. It walks you right through it. For this one, you can have them count backward from 100 by sevens, but I will tell you, I probably couldn't even count backward by sevens because numbers are not my strong suit. So you could also have them spell world backwards. And then it just kind of walks you through that, and copy the picture. There's 30 points available. And so you can have them do that one. And then it gives you the interpretation of what kind of impairment there is. So you can use this one, or you can also ask them to do the US University mental status exam. And it's, again, kind of similar to the MMSE, but it's a little bit different. It has some money questions. It does have the clock face on it, sort of a combination. So you could choose to use this one as well. And then it gives you the score down here. And so you're comparing the mini cog to either the MMSE or the slums. And then if you go to the assignment, which hopefully it takes you to, there you go again. And so then you need to write a little reflection, you know, answering these questions. Was it easy or difficult to administer? How did the patient think it was? You know, when you compare it with one of the other assessments, do you think one is more accurate? You know, and then which, in different settings, which ones would you prefer to administer? I am recording. Yes. Yes, she is. There's a core. Okay. Just checking my chat. Sorry. Okay, cool. And due on the 15th. So you guys should be able to do that in clinical on the 10th, or then you have a couple days in there if you prefer to do it on family or friends. It does not have to be somebody that you feel is impaired cognitively. You can if you want, but it's more to get you used to asking, again, these types of questions, that type of thing. Questions on that assignment? No questions. Okay, hearing no questions. Yay. And we'll move on here. And then I wanted to show you the supplement. Oops, there we go. I'm like, my internet is taking a while here. You have the supplemental information. There's a Romberg balance test. It shows you there how to do a diabetic foot exam, which is also for neuropathies, hearing screening, the OAE or ABR. There's two different types there, which we'll talk about, the Weber and I guess Rhin test. Also how to administer eye drops, how to administer eardrops for children and adults, because there's a difference there. And then this is a little link to different medications for dementia. And here's an example of how to administer the mini-cog, the MMSE, the slums. I threw in the spices. There it's almost more of an ADL type thing. And we've kind of talked about that before. And there's the slums and there's how to score the slums. So you have all those resources available to you. And then for the sensory perception, again, we'll go over pretty quickly through the PowerPoints, and then we're going to work on the case study questions. This is in IGGY, the Developing Clinical Judgment book. It's not, we haven't used this book yet, so I wanted to get into that. And then what you're going to do for your assignment for that is, here's the chart. It's just a chart to fill in, but it's going to help you hopefully categorize the differences. So here's the adult vision type things, the pediatric children vision things, and then adult hearing and child hearing. And we're going to speak to those in lecture today. And if there's any notes or anything you want to keep that, add there. So it's kind of like a study guide for you. Except I forget when the due date was for that. Oops. I'm trying not to stack too many due dates on you. November 13th, so that's due by Friday. But we're going to review a lot of it today in class. And then please include one reference. So you can just put your textbook or Giddens or whatever you'd like. Questions on that assignment? No. Okay.
Oh, sorry, one question.
Yes.
For the interrelated concept, would that just be our sensory perception?
So what, and you'll see these in the PowerPoints too. Okay. So you get some ideas from the PowerPoints, but what, if you have if your sensory perception alteration is in vision, is altered vision, impaired vision, then what other concepts might you also need to do teaching or be worrying about assessment, those types of things.
Gotcha.
Mm-hmm. All right, so let's start on cognition, which of course opened in a different screen. What do you guys know about cognition? What have you seen in clinicals so far? You had patients that have cognitive alterations?
So I don't know if this is exactly what you're looking for, but I had a patient who had taken her nasal cannula out and she was low on oxygen, and she was definitely, kind of just not as present as she was once we got it, back in and got her O2 sat back up. So that was kind of interesting to see. It was a very stark contrast in her personality.
And so that's why you need to know your beginning assessment, right? That's why you walk in and you look at the patient initially, so that at some point during the shift, if there's a change, you notice the change, or you notice that the cannula is out or whatever. And yes, for sure, some dementia patients, definitely. Can you see the PowerPoint? Is that what you're looking at? Or are you still looking at?
PowerPoint.
Ellie's nodding. PowerPoint, thank you, Amy. Okay, so start from the beginning. And I will try and highlight for you the, there we go, the things that, oops, oh my, that you need to know. So these are just the, your objectives, right? And so that's what we're going to talk about. So when we talk about cognition, right, it's acquiring knowledge, right? So if you think lifespan, it's how does a person acquire knowledge, young and old and in between. And then how do you understand the thought through through thinking about it, through the different experiences, as well as your senses, which is what's going to lead us to our sensory perception in the next section of lecture. There we go. So you guys can put this in the chat if you want, but what are the meanings of each of the following terms? When we're talking about cognition, what exactly is, perception? What is memory? What is executive function? So we have nobody in the chat. Okay. It's okay. So let's start with memory. What's memory? Whoops, sorry. You guys need memory for this course, right?
It's the ability to recall information, short-term and long-term.
Yeah. Right, so you have short-term memory, long-term memory. Can you remember something? So that's why in a lot of those status exams, mental status exams, it's asking you to recall information. And some of it's short-term and some of it's long-term. Good. What about perception? Because again, that's going to tie us into sensory perception.
I think for perception is probably what we think we see or something like that, Ms. Sullivan.
Yeah. So that's one way to say it. Yeah. So this has to do again, like when you're doing your assessments, like you're interpreting the environment, like what do you see? And then based on the input that you're getting, what do you do with that information? And so what's your perception, right? Because we can perceive things differently. There's a saying that goes, your perception is your reality, right? And so depending on the different stimuli, depending on your cognition, your perception of the exact same situation could be different. And then what about executive function?
That's the ability to like organize your thoughts and then to like what you use for this class, right? To organize your thoughts and then to carry it out.
Yeah, that's a good way of saying it. So I think I like to think of Piaget when you start with like sensory motor and pre-operational and concrete, and then you get to formal operations. I kind of feel like executive function is like formal operations, right? Because you can adapt, you can think ahead, you can be flexible, and you can think ahead, right? You can, think about what could happen. That's what executive function is, right? And so then how do the terms relate to the concept of cognition? It's not a trick question.
Those are all functions of cognition.
Yes, they're all different parts referring to human thought, how we think about things, and that has to do with cognition. And if we have altered cognition, impaired cognition, then that affects those functions. So the continuum, right? High order cognitive function, basic order, and then if you have some type of impairment, mild to severe. I think what's interesting is that the continuum can change over time. It obviously grows through the lifespan, but then can, based on different events or things that happen physically, emotionally, it can change over time. And so this is just a slide that reminds you where the parts of the brain are. I just have this in yellow because it talks about perfusion and oxygenation and nutrient-rich blood, nutrients, right? So those are also concepts. But you need to, if you don't perfuse the brain, if it's not getting the nutrients and the oxygen that it needs, like what was that, Kelly? That was your example, right? You walked in and the cannula was off, right? That's exactly what happened. So the perfusion, the oxygenation decreased. And so then that affected brain function. Great example. And so different examples of impairment, delirium, which we're going to talk about. There can be different neurocognitive disorders. You can have cognitive impairments that aren't dementia, focal things, intellectual disabilities, learning disabilities. We're mostly going to focus on delirium and dementia. We're going to talk about that in a second, but there can be learning disabilities. We'll talk about that when we talk about growth and development and PEDS a little bit more in next semester. And so we want to talk about delirium and dementia. What do you think what's the difference between delirium and dementia?
Delirium can happen to somebody who isn't technically impaired. It can come about from outside situations.
Mm-hmm.
Whereas dementia is kind of, I don't know if you can recover from dementia.
And is dementia age related usually as well?
Probably it could be related to other disease processes. So depending on the age that you have that disease, you could have dementia. Delirium, sometimes you see, when somebody's hospitalized. And so if you take like an older person out of their normal environment, they get disoriented, right? And that would be considered delirium. Now they might also have dementia on top of that, but if you took an elderly person, that's just like one example, you put them in a different situation and they're like, I don't want to say delirious, but they're delirious, right? They're out of touch. They're not really sure what they're supposed to be doing. They're confused, they're incoherent. They can't remember things, but it's reversible. So like you were saying, that's reversible, whereas dementia is more of an organic type thing. So good.
Can I ask a question?
You may.
So one of the patients at the Ridge, she kept asking me to let her cat in because the woman next door was yelling and she thought that she perceived that as her cat. Is that
Oh,
is that just
wow.
the dementia or is that delirium?
My thought is that it's probably dementia because of the population that you have there. I would have to assess that patient. But that's their perception is altered of what it is. So I would think that would tend to be more dementia. And so then oh, go ahead.
I'm sorry. I guess I'm confused. Like the delirium is something that it's just an altered cognitive state that you don't understand reality. And then dementia is an altered state where you don't understand reality.
Okay, no, I hear you. So delirium is reversible. It's hard to focus. Like your memory and judgment may be impaired. Sometimes your speech is altered. Like when you're coming out of anesthesia, I don't know if you've had anesthesia before, but like, it's like, what am I hearing? What am I like? Whoa, you may hear things or see things. Whereas dementia is generally speaking it's like a slower process. It's not something that happens bam, like that. Dementia happens like over time.
Okay, got it.
And that's why I would say that with the residents at the Ridge, it's more than likely dementia because a lot of them are older. A lot of them do have some type of dementia. However, it could be if they had maybe received too many opioids or, or if their medications are not working correctly, and then it could be delirium. But if she was thinking about the cat, it should stop at some point. But my guess is that probably when the roommate keeps making those noises, that it's always let the cat in. I don't know if that helps or not, but delirium is generally transient. So when you have cognitive impairment, you have different consequences. And so if you think about like risk for injury, right? You know, the safety, falling, taking wrong medications. It's really difficult can be really difficult to manage, you know, take your medications, do your exercise, eat correctly, whatever it is that you need to do to manage your disease process. We've also talked about functional ability. So perhaps the person with a cognitive impairment isn't able to really take care of themselves independently or to have normal social interaction. And so they might need more assistive services. Sometimes it's a financial hardship. If you have to put somebody in a place where they can get the help, that costs money. And then we haven't really talked a lot about caregiver burden or caregiver stress, but for the person that's taking care of them, it can be a big burden, and it can be very, very stressful. Which actually, let me ask you this one. So the caregiver burden, I think of that generally in terms of when they're at home, but what do you think about when they're either in the hospital or in a long-term care facility?
That would be nurses or CNAs.
Right, and so do you feel like they could get burnout, or that they could, you know, eventually have, it could be a burden on them? Excuse me.
Sometimes, yes.
Mm-hmm. I mean, I know at the Ridge, generally the CNAs have the same section, you know, every day that they're there, which on one hand is really good because you get to know the residents, but, you know, perhaps it could be emotionally, physically taxing. And I think, what about in, what about in a hospital situation?
Like at SVMH, I noticed that the CNAs will talk amongst each other and ask the charge nurse if they can change patients if they have a heavy load. That way everyone can have somewhat of a same type of load. I noticed that a couple times already.
Nice. That's a great example, Vanessa. Okay, risk factors. So there's basic general risk factors, and then there's some individual risk factors. And so the elderly population is the population at highest risk. There's really no differences noticed according to studies based on race, ethnicity, or gender. There are some risk factors more specific to women: poor health status, sense of dependency, lack of social support, insomnia, and then risk factors more specific to men being history of stroke and diabetes. And then more individualized risk factors, if a person is engaging in high risk activities, substance abuse, as well as injuries. There are a lot of, I've worked with patients that have traumatic brain injury. That's not something we're covering right now. We'll talk about that next semester or third semester. Excuse me, but you put yourself at risk for injuries, different environmental exposures, and then looking at genetic conditions or congenital factors, because sometimes if the mother has a history of substance abuse, then the child can have some type of cognitive deficit, birth injuries, asphyxia. You can have things like cerebral palsy, and then different types of health-related conditions. Sometimes the condition itself or the treatment can lead to cognitive impairment. And then, so how do you assess? How do you recognize that somebody might have a cognitive impairment? Well, as always, right, history taking, right? You're going to take that history, ask about, the family, ask all those things, where have they worked? And then on examination, what do they look like? What's their general appearance? What type of behavior do you see? And then you can perform different assessments that talk about cognitive functioning, like the ones we talked about, the mini-cog, the MMSE, the slums. There's a couple other ones, but those are the ones that we're going to focus on. You kind of have to rule out any organic, like medical problems. So for example, say you're in the long-term care facility and a resident who doesn't have dementia becomes confused. And let's say they have a suprapubic catheter. So what might the cause of their confusion be?
UTI.
could be a UTI, right? And so what laboratory tests would you expect to be ordered? If you think it's a UTI.
CBC?
A what?
CBC?
For a urinary tract infection? Yeah, I mean, you could.
UNA. UA.
Yep, a UA and a CNS, right? A UA and a culture and sensitivity, and probably yes, as well as CBC. And then that's going to tell you that we're going to just say then that they have a urinary tract infection. We treat it with probably a cephalosporin, and then their cognitive function improves, right? So that's when we used a laboratory test. There's also different neuropsychometric testing that's on the next slide that you use to, we're helping to diagnose, or we get a baseline that can help plan treatment. And you can do MRIs and CT scans and all those kind of things, which is kind of beyond what we would do. So when you're doing the neuropsychometric testing, and I'm not going to ask you questions on neuropsychometric testing, I just wanted you to kind of understand what that meant. So the reading comprehension, how to use language, your attention, your motor speed and dexterity. So they might ask you to do certain tasks. And then there's your executive functions again. Can you, make judgments and multitask? And that's what a lot of these, the cognitive assessments are. That's what they measure. That's what they do. And so then what can we as nurses do? What kind of primary prevention can we perform? So like we've been doing, what you guys have been doing, promoting a healthy lifestyle, right? Staying active, eating correctly, not doing high risk behaviors. And then you can, those can be community programs. It can be one-on-one. Oftentimes you can get genetic counseling. I know that, sometimes when you have one child that has an impairment, regardless, you're going to go to the genetic counselor and they'll do DNA analyses and things like that. So that's available. And then different practices to reduce the risk for delirium. So making sure that you're not in situations that could place you at risk for that. Or I would think to understand that if I'm doing part of my pre-op teaching should be that post-op, when you start to come out of anesthesia, this is what you're going to experience. Does that make sense? Yeah, hopefully. Okay. So secondary prevention in terms of screening, unfortunately, there's not really any evidence to, say, yes, there is screening that we should do, or we shouldn't do it. The screenings that we do have are somewhat helpful. They kind of lead us in the right direction. But to, I don't want to say it, so screening like a mammogram, right? We know there's evidence for a mammogram every 3 to 5 years, depending on your history. But we don't have anything like that evidence to say, yes, you should get this particular screening done for your to assess your cognitive function every so many years. And then I've shown you those examples, and there are some others. But what do you think about if you are, when you go to do this, you're going to administer this mini cog, and then these other assessments, what barriers might you face when administering these assessments? What might skew the data, in other words?
Language barriers.
Language barriers, yes. What else?
Decline mobility.
I'm saying, say that again.
Decline mobility. A lot of people that we saw were contracted. I mean.
Yes. So how can they draw a clock, right? How are they going to be able to draw a clock?
On meds, maybe something where they're quite sharp because they're on pain meds.
Yeah, exactly. So different medications. Maybe they're nonverbal.
John in the chat said education.
Oh, sorry, I can't see the chat. Sorry.
Yeah, I figured that's why I didn't know.
Thank you. Yes.
Francisco said weakness, pain. Amanda said literacy.
Yes, literacy. There we go. That's the one I was looking for. But yes, all those other things. Right. So just in terms of knowing that when you're administering or when you're doing an assessment, what are some of these things that you could, that could prevent you from getting accurate results or being even able to perform the assessment, right? Some of the patients that we've seen in long-term care, there's no way that we can perform this. They're nonverbal, they're contracted, there's just so many factors. But I think mobility in terms of, can they write what they need to write or draw what they need to draw? Can they read it? What's their literacy? What's their language? You know, I think those are all very important factors to take into consideration. And then more collaborative interventions, you know, whatever the underlying cause is, always safety first, safety. If you can you know, anything that's going to affect them in the future. Also, I think it's really important for people that do have cognitive impairment. It really is interdisciplinary treatment, right? There's probably some medications, there's nursing interventions, you're gonna have, you know, nutrition, maybe they have speech language issues, hearing issues, some of these other sensory perception issues that we're gonna talk about that's hindering them. Home health follow-up, those are all good. And then, you know, general health and comfort, reorienting. So we have one patient at the Ridge that tells us that she hears voices. And so the students were asking me, well, what, it'd kind of be like with the cat as well. So if you can reorient them, you know, you might say, you know, I understand that you're hearing a cat right now and that you'd like me to let the cat in. However, I'm not hearing a cat or seeing a cat. Your roommate is making some noises. Perhaps that's it. That's what you're hearing. Or trying to reorient them. May or may not work, but sometimes if you do it enough, it will help. Like you were saying, pain's a problem, so keeping the pain under control, keeping the stimulation decreased. I'm thinking like children that are on the spectrum, right? You want to decrease stimulation, positive rewards for proper behaviors. We're going to talk about hearing aids or other types, you know, different types of like corneal transplants, things that can help, or there's different glasses or things for vision. And then I think really important is caregiver support. You know, hopefully there's support groups for these caregivers. I know there's an Alzheimer's support group, several in the county. And I think those are really important. So pharmacotherapy, you guys don't have to know this for 46, but I wanted to put it out there just so that you at least had heard some of the terms. We actually, at the Ridge, I think I've given memantine, which is Namenda, which is a cholinesterase inhibitor. I don't know if you guys I don't think you guys are here yet in pharmacology. They control more of the behavioral things, or are supposed to keep the cognitive function where it is and not declining, or not declining as quickly. And then you also have these glutamate receptor antagonists, the NMDAs. So again, it just shows you how it works. Again, you don't have to know it, but these are the two most common ones that I see in practice, the donepezil and the memantine. So just in case you see those or hear those. And then, so here's your interrelated concepts. What happens when your blood glucose drops to like non-readable on the meter?
You can become unconscious.
You can become unconscious, your mentation changes.
Yeah,
right?
Kenya put coma.
Yeah, exactly, right? That's a change. You know, you have to have good perfusion, gas exchange, nutrition. We talked about that. If you have impaired cognition, then mobility can be an issue. We didn't really get into intracranial regulation, increased intracranial pressure, but that and acid base have effects on cognition. And then of course, development and functional ability, cognition affects those as well. And so Alzheimer's is what we're going to talk about. We're going to go over that in the next one. And then so basically what you need to know is the different risk factors, primary, secondary prevention strategies, the difference between delirium and dementia, know the common cognitive assessments, which you're actually going to, you have an assignment for that. What kind of safety measures would you think about implementing, interdisciplinary measures, and then the interrelated concepts, which we just talked about. So questions on that? Do you know what you need to know? Hopefully. Oh, there's the chat. Yay. Okay, cool. Okay, so let's do the Alzheimer's one, and then we'll take a little break and move to sensory perception. Have you guys worked with patients, or do you have friends or family members, not to get too personal, but that have Alzheimer's?
Oh boy, yes.
Oh boy, yes. Are there any characteristics that you see across all those people that you know, like patterns that you start to see?
I would say that social conversation is the last to go. And so a lot of times when someone would come in to do an evaluation, they would have pleasant small talk for about 15 minutes, and they would be perceived as having all their faculties, working fine. But it's like, for the people who were living with them 24/7, the holes in the memory and all that are much more evident.
That is so true. We had a patient when I had students not at the Ridge, but I had students at PCPA, where the third semesters are right now, Pacific Coast Care. And there was one lady in the memory care unit, which is a locked unit there. And I had students over there, and they would speak with the lady, and she was an artist, and so she had drawn pictures, and she would draw pictures of them, and she would show them pictures of her family and talk about, open her screen door and kind of step outside for a little bit and then come back in, and always was rearranging her bedside table, needed to unpack some boxes because could the students help her with that? And they would come to me and they would say, well, why is she here? She's making sense. I said, give it another 10 minutes, go back in the room and see what happens. And what happened was, what do you think happened?
She probably repeated the whole conversation over again.
It was the exact same conversation. She didn't remember them being there earlier. Like, she knew somebody was there, but she didn't know it was the same students. And in the exact same order, went through everything that she had done before. And then they would come back to me and say, oh, I see what you mean. I see what you mean. So yeah, it's very interesting. All right, let's take a look at this. So we're looking at, you see the PowerPoint, cognition, Alzheimer's disease. Yes, maybe, hopefully. Okay, let me do.
Yeah.
Thank you. I think that was Amy. Guessing that was Amy. Oops. There we go. So you have your objectives posted. So we're just looking at Alzheimer's as an exemplar of cognition. So in Alzheimer's, we've learned a lot more, but there's still a lot that we don't know, but there are structural changes in the brain. It comes in stages, which come on the next couple slides. And then certain symptoms that you'll see, different diagnostic testing that they can do. And then the priority of care would be supporting the patient and the caregiver. And I always say safety is a big thing as well. And so when you look at early stage, that's mild. So some of the difficulties you see are listed there. Difficulty performing tasks, forgetting things that were just read, misplacing or losing things, coming up with the right word or name. Gee, this describes me. Okay, remembering names when introduced to new people. And so the symptoms kind of come and go. You see them here and there. Sometimes it's hard to pick up on the pattern. And then you have moderate, middle stage, moderate Alzheimer's, which is generally known to be the longest stage, can last for years. And then the level of care that's needed increases as they move along this path. And then you get the nerve cells are damaged more and more and not remaking themselves. You're not making the new synapses as well. And so then you start to see some of these sort of symptoms, being able to choose proper clothing, let's see, I don't think I can, nope, can't see the chat. And they start maybe become incontinent, sleeping issues, more insomnia, generally speaking, restless at night, wandering, right? Wandering can be a big thing, right? You see those alerts, so-and-so left, we can't find them. And oops. And so that you can still participate in daily activities, but they need more and more assistance. And then late stage or severe, you know, they require around the clock assistance. They really, they lose awareness of recent things. It's mostly things in the past. It's difficult to communicate, and then also can become vulnerable to infections. And so this is Alzheimer's is the most common type. The cause is really unknown, but there are the structural changes in the brain. Age and gender and genetics is what they're finding. Whereas we talked about risk factors really weren't a lot in gender, but they are finding as you get older, it increases after 65 years old. And so when we talk about assessment or noticing, right? So you're looking at the cognition, right? Behavior, right? So knowing your baseline, how the patient cares for themselves, you know, thinking psychosocially. I don't know so much lab, but like imaging. They can see brain changes on imaging. And so then interpreting, once you've gotten your assessment and you've looked at all the data, and then so what are problems that you see? So the memory and cognition are decreasing. Here's where the increased potential for injury, the wandering, mobility can be affected. And then something that we haven't really talked about, but the potential for elder abuse can increase because of their increasing care needs, the stress on the caregiver, or it's kind of going back to that circle of life kind of thing, because when you think of children and child abuse, a lot of times it's because the parents don't understand what the expectations or the, you know, what they need to know, what the child is or isn't capable of. Well, it's sort of the same thing. So I'm taking care of a person that used to be able to do all these things, and I'm really not quite sure what they can or can't do. And then when they lose their ability to be continent and I have to change the sheets all the time, I get mad at them. Does that make sense? If you're sort of looking at it in that aspect? Yes, no, maybe?
Yes.
Thank you, Amy. And then responding. So what are we going to do? So safety, right? Always the priority. So you can use non-pharmacological interventions in terms of like the refocusing, the safety things, the drug therapies that I showed you, and teaching, you know, education about how to stay safe, home safety, and how to not only prevent, but recognize when there is elder abuse happening. And how do you determine, is it a story? Is it real? We have a patient at the Ridge. They're told to, the students are always told to go in 2 at a time because the patient always accuses somebody of doing something. But you kind of have to take those you have to take them sort of for real. And then so home care management, hopefully you can get some respite care, but again, you're looking at insurance, right? Who can afford these types of things? You know, emphasizing mobility, and then any healthcare resources. I did not look up the Safe Return program. I apologize. You guys can look that up on your own. And again, I would say support groups for the caregivers. Okay, here is a question. We can answer the question and then take a 5-minute break, bio break. So the family of a patient with Alzheimer's disease reports increasing symptoms of paranoia, right? They're like paranoid, like somebody's after me, something's going on. Which nursing response is the most appropriate? So there's often an underlying psychiatric condition with Alzheimer's disease. Some patients with dementia may experience paranoia, delusions, and even hallucinations. This is a sign of rapid progression of the Alzheimer's disease, or inform the patient that their feelings are not real. B? So I have a B. What do other people think? And I can't see the chat.
It
Yeah,
looks
the
like
chat's
it's
blowing
all
up with
in
B.
the chat. Yeah.
Oh, thank you. Okay. Yay, the answer is B. Woohoo! Right, that's your best answer. That one, don't you wish they were all like that? That one's kind of, yeah. Oh yeah, I see Crystal's comment. Some days are good for them and other days you can notice it more. And so sometimes the family or the caregiver, oh, they're getting better. Well, they don't really get better. It's just a better day for them. All right, go take a 5-minute break and then we will come back and work on our little cataract case study and talk a little bit about the sensory perception. Zoom. So to recap, the Vision 2020 will help you with complete your chart. You don't need to know the meds. You just need to know the disorders. And the same thing for the Hearing 2020 PowerPoint. If it pulls up here, again, taken from previous lectures that I have done, information for your compare and contrast chart. So it is kind of important to understand external, middle, and internal ear, and it shows you that there. This is the middle ear. And then, so again, anatomy, different assessments that you can do, which you're learning some of this in your neuro, I think, assessment. And again, I don't really care as much about the different tests, just that there are tests. There are different medications that can help with hearing, different nutritional things that you can do for some hearing impairments. What you do need to know is the difference between conductive hearing loss and sensory neural hearing loss. So a conductive hearing loss, when there's some kind of injury, disease, and so the sound waves can't get to the inner ear, which is where the nerves are. So for example, wax buildup, if there's like inflammation, things like that, and you'll have like a conductive hearing loss. So for example, if you take your cotton balls and put your cotton balls in your ears, that would be what kind of hearing loss? Hello?
Conductive.
Right.
Nothing.
Yeah, you put your cotton balls in, you can't hear me. I get it, right? It would be conductive, right? And so sometimes people can't hear, and it's good to know if it's a conductive hearing loss or sensory neural. Sensory neural, which you can remember because it has the word neural in it, I think that's the way I remember it, has to do with the auditory nerve and the auditory center in the brain. And so it's actually a malfunction of the inner ear where the impulses are not getting to the brain, right? So you need to know that. And then here's like hearing aids, and they're much better than this now. There's little teeny tiny ones, like you can't even tell that they're there. There's actually hearing ear dogs, cochlear implants. You can teach people how to do lip reading. But hearing, a lot of times people don't even want to deal with it, right? They don't want to, they know they can't hear, but they don't really want to do, there's a cochlear implant, but they don't want to deal with it. So trying to get them to actually use a hearing aid can be difficult. Just some other things that can happen. Tinnitus, right? The ringing in the ears. Excuse me, Meniere's, where you get the fluid keeps kind of sloshing around in the semicircular canals, and so you get really dizzy. I've suffered from that. I cut down on my caffeine, and that really helped a lot. And then again, medications you don't need to know, but just so that you have them there. All right, so what do you need to know for hearing?
Conductive and neurosensory hearing.
Sensory neural. Mm-hmm. There you go. And so then if we look at Iggy's chapter, Again, you'll have that's a wrap slide that will talk to you about that. Some of the same things are in here that were in that other presentation. The exemplars that she uses are cataract and glaucoma. So you also will have to know glaucoma. But that's the only piece of the sensory perception that we're really focusing on. So when you talk about cataracts, it's that film kind of over the eye. Not much pain at all. There's a little picture of it there. And so this is kind of what it looks like. Here's what I don't know if you've seen some of your clients, like my dog actually has cataracts, and there is a difference. You can see a difference there. And so safety is an issue, right? They can do cataract surgery, break up the lens, take it out. So post-surgical, right? They're going to give antibiotics. What's subconjunctivally? Under the conjunctiva, right? Below. Dark glasses. Why would you do antibiotic steroid eye drops?
To limit infection if there's any cuts, like after LASIK.
So antibiotic, right, for infection. And what about the steroid component?
It'll reduce the inflammation?
Yes. Mild itching is normal. If there's pain for this type of surgery, then there's a problem. And then so this is intraocular pressure, so the pressure in the eye. So what's a time when we kind of just normally increase our intraocular pressure? Think elimination.
Pooping.
Yes. And so what do we hope that the physician orders so that we don't strain when we have a bowel movement?
A laxative or a stool softener?
Probably a stool softener. Good. See, you know that. So you don't want any floating shapes, anything like that. Make sure they know how to use eye drops. That's always good. Glaucoma is the increased pressure. And so oftentimes this is the one that you'll see the halos. People talk about halos. And there's two different types, open angle and angle closure. And so this kind of shows you, again, goes back to anatomy. You can look it up in those chapters. But it shows you, it's really the fluid, and the fluid just kind of goes around the eyes and bathes the eyes. And then when it gets blocked, when there's some reason that it gets blocked for whatever reason, then there's this huge pressure. And what ends up happening is that it can change the optic nerve. See the optic nerve back there? So that's not good. And so then this is a diagram that shows you the open angle, where there's still, there's an opening here, but the fluid can still build up. And then this would be the closed angle. Don't ask me how this all happens. I can't remember, quite frankly, but just know that there's two different types, and they're treated differently. And there's a lot of not screenings, but you can get your intraocular eye pressure checked when you go to the optometrist. That's when they do the puff of air. Again, looking at eye drops, you can do surgical management. So then other ones, macular degeneration. So we're talking, in this case, we're talking age-related macular degeneration. There are other types, Stargardt's disease, for example, which my son has, but you lose your peripheral vision. You lose your central vision. So all you have is your peripheral vision. So when you look at somebody, you can't see them. You have to kind of turn your head or find other ways to actually look at the person. And then another inflammation of the retina. This one's genetic, retinitis pigmentosa, and that's kind of what their vision would look like. I always love these kind of pictures because I'm like, wow, I'm so blessed and lucky to have my vision even with glasses. Detached retina, so trauma, right? And so the retina can become detached. And so You're going to see sudden flashes of light, some floaters, debris, like in the visual field. And so that's like an emergency. They need to get to the emergency room. And then just so you have pictures of these, myopia, like near, far vision, astigmatism. I also have astigmatism. Is there anything I don't have? Probably not. So let's do a couple practice questions. So there's a patient that has had decrease in the visual acuity in the left eye. He thought he had smudges on his eyeglasses, but it continued, and it was determined that he had large cataract that required a surgical removal. And so the patient asked the nurse why the cataract only affected his left eye. And so what is the nurse's best response? Oops, sorry. And so what is something that that the nurse would say? Right? Are cataracts going to be in both eyes at the same time?
No.
They can be, but it can just be one side, one eye. I think I'm missing the, so then they're going to go see the ophthalmologist, and they're scheduled for surgery. So what pre-op teaching would the nurse provide? Remind him that immediately after surgery, he'll have his best vision. Tell him that after surgery, he'll no longer need to wear eyeglasses for reading. Instruct him that after surgery, different types of eye drops will be prescribed for 2 to 4 weeks. Caution him to avoid wearing dark glasses because the retina needs a direct source of light for best vision. Look at that guy. You guys are all on it. C, correct. The patient's in the recovery area, and the nurse is preparing to administer eye drops and other meds. Which order for the patient would the nurse question? Which one are we worried about? The warfarin, a steroid, ophthalmic ointment, antibiotic, ophthalmic ointment, acetaminophen with oxycodone. And why are we worried about A?
It's a blood thinner.
And why is that a problem?
Because they just had surgery, and so the vascularization of the eye needs to be protected.
Yep, there you go. You guys are getting it. Yay! Okay, post-op teaching after recovery. Which statement indicates a need for further teaching? So this is a Sesame Street question. 3 are similar, 1 is different. So a need for further teaching. Yep, we do need the coagulation to happen. I will wear dark sunglasses. Aspirin will help decrease discomfort. My daughter will help me if I need to lift something. My surgeon needs to know if I'm experiencing reduced vision. And why is B indicate a need for further teaching?
Because aspirin is an antiplatelet, so it'll make the blood like run more if she has any problems.
Right, Emily, very similar to the question above. Nice. And then there's also some audience response systems. So which post-op outcome would the nurse anticipate for a patient who has undergone surgery for cataract removal? You guys are on top of it. Either that or you're looking at the notes on the PowerPoint, but I like to think that you're on top of it. So we'll just go with that. What priority teaching would the nurse provide to a patient who has received a corneal transplant? So we didn't really talk about corneal transplants, but still you were talking about the cornea of the eye. So what is the priority? So we took out keep the eye moist. So that's true. And keep the eye covered for the first 24 hours post-op. That doesn't, you don't have to cover the eye. So we're on signs of infection, and we're on avoiding straining to have a bowel movement. Right? And so signs of infection, are important, yes. But if they have a bowel movement and they strain, they can detach the retina, or the cornea can come detached, right? So C is actually the best answer for that question. And then, oh yeah, this one, I didn't know this one, sorry. Which patient is at greatest risk of developing primary angle closure glaucoma? And you won't get a question like this because that's kind of beyond what I expect you guys to know. So it's actually any patient over, I think it's 40. So that eliminates B. And it's actually females greater than males. And it's actually Asians greater than Caucasians. So A is the correct answer. So here's your, that's a wrap, right? To differentiate between the different types of alterations, and they're listed there, and that's from your chart. All right, so let's go to, and then you guys also have the hearing one, which you can look at. What I want to do, here we go. So I don't know if people, can you see, it should be the developing clinical judgment. Is that what you guys see?
Yes.
Okay, so I don't know if you're able to do this in your resources for this book, but this is what I have. There's a study mode and there's an exam mode. And so I don't know if you guys are able to access your book or brought your book. Find the right chapter. So the thing that's nice about this book, the reason I haven't used it previously is because it talks about a lot of complex things that we're going to talk about in second, third, and fourth semester. But for the sensory perception, the cataracts was pretty basic. And so that's why I wanted to at least get you familiar with the book. And so it actually has types of questions, formats of questions that will be asked. I'm not sure, I don't think when you guys take the NCLEX, but it's what's coming. This will be the next gen type of question asking. So what I would suggest is that you guys kind of keep track of your own answers, because you're going to turn this in the paper, page 85. Good to know. Yes. All right. Thank you, Greg. Do you guys want to like do breakout groups and kind of work on it on your own for a little bit, or you want to do it? You want me to just kind of go through it and show you the different types of questions? And then you guys can answer it or work amongst yourselves.
I say big group.
Big group. Okay. So for this one, and we're talking about a 68-year-old, right, male client presenting at the ophthalmologist's office for his annual eye exam, right? So we want to do that every year. And after the examination, the ophthalmologist reports there is no evidence of disease and the optic nerves are intact and healthy. Yay. However, client has a beginning cataract in the left eye and scheduled for surgery to prevent the vision from worsening. And he's scheduled for the cataract removal and insertion of an intraocular lens. So they're going to replace the lens. And so what preoperative health teaching would the nurse include for the client? And it's actually a select all that apply, which we just hold so near and dear to us. And so for these, you might have to look up what rivaroxaban, or watch some TV because the ads are there. You know, when you're going to need to stop taking that. And some eye drops to dilate. Be sure someone drives you to the doctor's office and takes you home to stay with you for the first night. You'll be on patient-controlled analgesia. It's like a pump, a PCA pump. Need to wear dark glasses or sunglasses. Operative eye will have a bloodshot appearance. May still need to wear corrective glasses or lenses. And you'll have to put several kinds of eye drops or ointments in your eyes a number of times each day, for several weeks. There we go. All right, so I have, let's see. So what do we know for sure? Is there any in particular? Or is there anything we wouldn't check? What is there one what's rivaroxaban? What does it do? So even if I don't know what it is, what 2 questions do we just have in that PowerPoint that were similar about similar about medications, right? And so if they're having surgery, they're probably going to need to stop taking that. And they're going to need to dilate their pupils. Are they going to drive home? No driving home. Bring somebody with you. So if they're driving home, are we going to have them on a PCA pump at home? No. So we're not going to check that one. What about dark glasses?
Yes.
A, B, C, G, H. Okay, dark glasses, yes. They might have a bloodshot appearance. So might they still need to wear their corrective glasses or contact lenses after surgery? So it doesn't necessarily change their vision, it just makes it clearer. So they may still need to do that. And then post-op, there's a bunch of different eye drops. How's that look? Should I click submit? Yes, okay, I will click submit. Woohoo! There you go. Correct. Yay! And it will give you the rationale. All right, let's see. Okay, so this is about safety. So you're 68, wait, you know what? I'm gonna find a different format of question. Here we go. So a 68-year-old male just had his cataract removal, insertion of the lens, new lens, and the nurse is preparing to teach the client's wife about post-op care. So indicate which health teaching listed is appropriate for the potential post-op complication. Note that all choices will not be used. So, for example, if the potential post-op complication is increased intraocular pressure, what health teaching are you going to encourage? So which one of these, number 3, I have a number 3 from Greg and Addie and Hugo, just not the number, right? Coughing, sneezing, lifting, right? Until after the follow-up visit. So does that make sense? We'll put that there. All right, post-op complication infection. Appropriate health teaching would you do for infection? So we're going with the last one. Okay, if the complication is hemorrhage. If it's hemorrhage, that's bleeding, right? We're going to assess for bleeding. So so number 1 talks about the eyelid. And we're talking about hemorrhage, so that has to do with bleeding. And then how about, unless you were moving ahead, eyelid swelling. There we go, right? Okay, and then last but not least, detached retina. What would we expect, or what would we want to teach them about that? All right. It says it's not painful. I always kind of thought it was, but it says it's not. The book says it's not painful. I've never asked anybody. I don't know anybody that's had one, but that's a good question. All right, should I hit submit? All right, I'm gonna hit submit. Yes, thank you, David. Look, correct, woohoo! And so that's a type of question where you're gonna have to select. All right, we get 2 of the questions done. Oh, this one's always fun. I like these. I'm terrible at them, but I like them. We'll do this one and then we'll be done. You guys can finish up the rest on your own. All right, so we still have our 68-year-old male for his annual eye exam. He's worn glasses since the 3rd grade, severe astigmatism and photophobia, which means the light bothers him. Currently wears progressive bifocal glasses to enable him to see both close up and at a distance for a correction to his 2010 visual acuity. After his exam, the ophthalmologist reports there is no evidence of disease and optic nerves are intact and healthy. Yay! However, he has the beginning cataract in the left eye, which requires surgery. Part of the pre-op assessment, nurse asks the client what meds he takes. He recalls most of his medication regimen, but the information is incomplete. So choose the most likely options for the information missing from the table by selecting from the list of options provided. So let's find one. All right, let's try the rivaroxaban because we talked about that a little bit already. So it's the medication, 20 milligrams orally once daily with the evening meal. It says the indication is atrial fibrillation, non-valvular atrial fib. And so what's the drug class? So it's asking you what the drug class. You probably have to look that up because we haven't really talked about that one. I'm going to give it to you. It's a direct factor XA inhibitor. Yep, there you go. Nice job, Francesca. Good job. Okay, so sildenafil, again, watch TV, 50 milligrams orally as needed. It's a phosphodiesterase type 5 inhibitor. And the indication for that is There you go. Okay, pantoprazole, proton pump inhibitor. Did you guys do GI meds yet? Yeah, okay. So pantoprazole, proton pump inhibitor for GERD, for reflux. So what is the usual order, dose, route, and frequency? Right, not sub-Q. It could be 20 milligrams, but generally it's 40. The 40 is generally, and it is PO, right? So we can take out the sub-Q automatically. There you go. And then our next one, it's a 5 to 10 milligram. Let's see, it is a second generation antagonist and it's for seasonal allergies. So filgrastim is related to cancer. Amlodipine mesylate is for hypertension. Spironolactone is what type of diuretic?
Potassium sparing.
Thank you. Yep. Antibiotic, cetirizine. So cetirizine is the correct choice. Okay, and then apremilast, 30 milligrams orally twice a day. It's a phosphodiesterase type 4 inhibitor. And that, so if you didn't know what it was, no, it's not gonna work. Never mind. Oh, that's not, I was gonna, yeah. So you probably have to look it up. So I have a psoriasis. A lupus. I will give you that one as well. That one is psoriasis. All right, gonna hit submit. All right, so that's 3 of the questions that we did in class. There's a couple more, and then the ones that we just did are not in order of what they are in your book. I just wanted to show you the different types of formatting of questions, and that you have this available to you as a resource. So there's only 5 questions and we did 3 of them. So that leaves 2 for you guys to turn in. I think it's tonight by midnight. Is everybody good with that?
So the questions in the book are the same as the ones that are online?
The ones that I'm just doing, yes.
Okay, so if we do it online, is there a report that we
I don't know. That's a good question. I don't know. I wonder, there must be some kind of like screenshot or something that you could do that would show you what your score was. If you can do that, or if there's some way to do that, I don't know. You could, I bet what you could do, hold on, because this is in the study mode. I bet if you went to exam mode, that it would, would record something. So you could do it in study mode and get all your answers down and then go take the exam. Somebody try it and put it in the chat if that works, because then you have to go in the order that it gives you. Let's see.
If we're writing this up, what format do you want us to, you just want like the 13-2 and then the answers, or how do you want us to?
Yeah, that's fine.
Okay.
So we're only submitting the questions that we don't do in class?
No, you're going to submit the whole thing, because you can't really submit just those. So it looks like this, if you do it in the test exam mode, it will give you the score here. So if you took a screenshot or did something of that, if you're doing it online, then you can do that. Otherwise, if you want to just write, 13-1 and whichever, number the questions, that's fine too. Does that work? I believe all the questions are in the hard copy because I have it in front of me. And it should be 1, 2, 3, 4, 5. Yep. Yep, they're there. Okay. Any more questions on that? And that was supposed to be mostly an in-class thing, right? That you're gonna turn in. It's like, what is it? 85, 84, 85, 86. Okay, we do that, we did that. All right. Any more? Okay, so let's, okay. So for all intents and purposes, class is over. And so then if people have questions they want to ask, I will entertain questions. And then we can also go over your hours calculations.
Ms. Solinger?
Yes.
To access what you had online, what's the easiest way? I feel like I'm always trying to, I'm jumping between different like websites and then having.
So that's on the Evolve. It's on the Evolve, or does somebody else have that? It's in your resources for Evolve.
Okay, I'll check that out. I hadn't, because there's the portion where you can like download them onto your computer as well. And
yes.
Like,
and so that's like the vital source. That's like the vital source library or page burst library that you have with Elsevier. I don't know. Like, I don't know if yours looks as mine, but like this is my library, and then it'll take me back to my Evolve, which mine's probably set up differently than yours. I don't know. I've never seen a student side. But if you go to my Evolve, like I have, it should have resources. And then for me at the bottom, it's the vital source library. And that's what takes me to my books. I don't know, students, if you guys have a different way of doing that. Oops, forgot to share. Hello, that's my library. And I go back to my Evolve. And so like, these are all my resources for like concepts and McQuestion, the psychiatric one. And then if you go to the vital source library, then that, oops, gives me like 10,000 versions. There we go. I don't know if your guys' is different or not, but because then once you, hold on, sorry. Once you go into the book, so like, for example, elimination, I have things that are highlighted. If you guys are following my highlights, then you'll see what I have highlighted. I don't highlight everything. I don't know. How do you guys get into the resources? Is it similar to what I was showing you or no?
Mostly I use my hard copies.
Yeah, I just look at the hard copy.
Yeah. Even though the company says, oh, everybody's looking online. No, you're not. You all want hard copies of everything, which is fine. I look at my hard copies. Okay. So let me, what other questions do you guys have? Hours, that's your question. Okay, so yay. All right, so let's tackle 46 first. Let me find, hold on one second. Let me look up something here to show you. No, that wasn't it. Yes, that was it. All right, so let's take that one. And then I need to go back. Hold on, let me look up one other thing. Bless you.
Oh, I'm not muted. That's funny.
No, you're not. It's all good. Okay.
It happens.
There we go. Okay, now I'm good. All right, so let me share my screen here. Okay. Do you guys see Thorpe's schedule there?
No, we see a scuba diver.
Oh, never mind. Try again. Let's try that one. No, it is that one. Still the scuba diver?
Now we see the schedule.
Now you see the schedule. Yay. Okay. All right. So everybody's schedule is basically kind of the same. So if you go back to week 1, right, we were at SVMH. So I should probably pull up the comportment tool too. Sorry. So we had X number of hours at SVMH for orientation, right? So right, and so do you see the comportment tool now?
Yes.
Yes, okay. So so the Tuesday you were at SVMH, and then the Wednesday, and you guys were doing health stream, right? So any of your, you know, the SVMH hours, what did people put for that? How many hours did you put for that Tuesday?
We were also, I believe, on campus that
Yes.
Tuesday. So I put hours on campus, 4 hours for SVMH orientation.
Okay.
And then I put 4 hours for the Thursday health stream.
Okay. So people should be consistent with the Tuesday. And I'm sorry, you said 4 hours at SVMH and how many on campus?
3.
3. Okay. That sounds about right. And then I don't think we had Vitas going yet. Any orientation, anything having to do with Vitas would go there.
We did have Vitas orientations that week.
So that's what that is. The 27th and the 31st. That's probably why I have that.
Yes.
So whatever hours you put in for that, I think it's an hour. Was it an hour? 2 hours?
For one of them, I have 1 hour. That was the recorded Zoom. And for the part 1 orientation and quiz, I have 2 hours.
Okay. So do people have similar things to that, similar hours to that?
Yes.
Okay. All right, week 2, right? If you went to do health stream, and then we had Tuesday was on campus clinical. No, people don't have those hours?
Yes, I have 2 hours for.
Yeah, 2 hours and then 4 hours on campus.
Right, because that Wednesday is when you should have been doing those for Wednesday week 2 and Wednesday week 3. Should have been those like the modules or practicing your skills, right? To be, I don't know why this is so slow. It's killing me. killing me, Smalls. Stop.
I have 4 hours for ATI on those Wednesdays.
4 hours? Okay. What it might, some other people might have more or less depending on how long it took you to do things. So do you see week 2? Is that on the screen now, week 2?
Yes.
Okay, thank you. And so, you know, doing your health stream, whatever long that took you. And then, so this was Tuesday, right? And then we came back on campus and worked on things. And then Wednesday, this is what you were supposed, this was when we still had that question for like week 2 and 3, and people are asking about the health assess. So whatever time you put in on Wednesday to review all these things and to work on all these things and to complete the intro to health assessment and the general survey, that goes in week 2 and 3 for that Wednesday. And if anybody happened to do Harold Stevens, you could add those hours. We actually never got to him, sorry. Does that make sense? Or help clarify a little bit?
Yes, that makes a lot of sense. I didn't record why the heck I had random hours. Like I didn't put a reason. And so I was like, I have these hours. Did I just make this up? So now it makes sense because we were supposed to be doing those. I put down skills review. So that makes sense. Yeah.
Mm-hmm. All right. And then let's check week 3. I'm just going week by week. I hope that's okay. But just so that we're all kind of, everybody can kind of keep track. Theory, so clinical. So this is week 3. See week 3 there updated. So this was on Tuesday, was on campus doing all the testing and all all that kind of thing. What to bring. And then Wednesday, oh, we were on campus on Wednesday, weren't we? I think we ended up being on campus.
Yes.
So however many hours you were on campus for that Wednesday, you would go ahead and put that.
For some reason, I have 2 hours Zoom that day. Did we do Zoom that day or no? The 9th.
Did we do, yeah, did we do? You might have met with your clinical instructor. Were there any groups that met with?
Ours did not meet with a clinical instructor that day, just the in-class stuff.
Okay. But any one of those days where you did a Zoom meeting with your clinical instructor, that would, you would put those hours down as well. Okay. Let me go back to the comportment tool and then we'll flip back and forth here. All right, so that should be, right, that's weeks 1, 2, and 3. Yes? Or talk amongst yourselves or figure that out. And then let's jump to week 8 because that's a different one, right? And so Tuesday, you had the EMAR Pixis training, and then I think you guys came back to campus that day. And or
Yes.
you did, and or you did your midterm clinical evals, which I think were actually on campus, most of them. I don't think Ms. Thorpe's group, but I think the other 3 groups did them on campus.
So how many hours do people have total for that Tuesday? Was that the 13th?
Greg, I have 2 at SPMH and 4.5 on campus because I believe we were on campus from 12:30 to 5.
Okay.
Yeah.
Yeah, I had 6.5 total, but I guess I didn't separate it very well. Thanks.
And then if you were lucky enough to get your VITAS hours, you would be adding any VITAS hours that you had you know, in the VITAS column. Right, so that's campus clinical, right? But there are still hours, campus clinical, and then we start week 4 is when you guys started in your clinical settings, right? And so then whatever hours you have for Clinica, which is technically the 4 hours, but there's a pre and a post conference. So you want to add those hours in for that. If you're at Clinica, there's usually a 1 hour pre-conference the Monday before, and then the 2 Wednesdays have an hour post-conference. And then whatever your SBMH hours are, and that would include, because I know some of you are coming early potentially to work on some things. I don't think, maybe staying late, I'm not sure. But those hours could be counted. And then any VITAS hours that you did, regardless if it was on the Wednesday of the week, right? So whatever you did for that week, the VITAS phone call hours, and remember it should be in 15-minute increments. So if you made contact on the phone, even if it's 5 minutes, 2 minutes, then that counts as a 15-minute block. If you did not actually speak to anybody but left a message, then you're SOL. It's no minutes. But if you just said hello and they said, I never want to speak to you again, and you said, thank you very much, and hung up the phone, that apparently counts for 15 minutes because you made contact. Hopefully they didn't say that to you.
Ms. Sillinger, I have a question on the VITAS. So the hours are between 35 and 40 hours. What about if we do over 40 hours? Can we still count it on our compartment?
Yeah.
Oh, okay.
Yeah. And then what we're going to suggest is for students that are have completed the 40 hours, if you're not wanting to make more calls, because you don't have to, we're trying to figure out, and I will check with Ms. Clark, but we're trying to maybe see if Claudia had a really successful call list, if maybe she can pass that can be passed on to somebody who still needs to do a lot of hours, right? Because we're having some lists where it's all Spanish speaking, but the student doesn't speak Spanish, or, you know, whatever the different issues are. So if the student has what we would consider to be a successful VITAS call list, that could be an option. Does that make sense?
On that one, for my list is very successful. I have really good clients that I alternate each week. Miss Clark and we tried giving it to Amy through my manager, Lauren.
Yeah, okay.
No, it wasn't successful. She told us no. We tried to see if we could transfer Amy from Atlanta to Florida. She didn't let us. It wasn't successful.
Why? Oh.
I can't remember the whole specific details, but I ended up CCing Amy and Mrs. Clark on it, and I was going back and forth with Lauren, and Lauren looked into it. She sounded like she wanted to try, but then at the end she was like, oh no, because, and I remember, because she says it's violating HIPAA somehow because she's in Atlanta, but we're trying to get her, like, for her to stop there, and she goes no, that she didn't want to intervene with Atlanta and Florida. So it made it that she was just trying to use the whole violating confidentiality in HIPAA, and it wasn't successful.
Okay, well then strike what I just said. Sorry.
Yeah.
Sorry about that. We thought that would be a great.
I thought the same thing. I literally told her, like, it literally is helping out one of our classmates. She really needs the hours, and it didn't.
Yeah.
It wasn't successful.
I'm sorry.
So I got an email from my team manager saying today that that I have to let them know a week before I finish because they have students on the wait list. So I don't know what wait list she's talking about. I don't know if it's other colleges or what.
Probably other colleges is my guess.
I would say so, the same thing, because I've been attending their meetings for communication, ethics, and stuff like that.
Right.
And they get like over 170 students participating from different colleges, because they'll put their name in there in the chat, because they need to trust
Wow.
it. And they said that the reason they created that is because the students need hours, the RN, mostly registered nurses, and they every single time that we're in the meetings, they make it clear, oh, for you nursing students, and like, you're welcome. And I'm just like, oh wow. So I think they're meeting different needs, from my understanding.
That makes sense.
Yeah.
And are those videotaped? Like, can people that didn't attend those watch them later, or is it just live?
I think they're just live.
They're
live.
Yeah, they're live.
I'm sorry.
I think they have about 20 different colleges and universities that are using them, because on the document that we document our hours, there's like a drop down button. And so it shows you all the different colleges and stuff that are part of it.
Wow. Cool. Okay. Okay, so weeks 4, 5, 6, and 7, then people are good if you went to, I don't think we didn't start the Y till the second half. So, and the Ridge till the second half. So, so we good there. And then week 8, we went over, right? And so then let's do that one.
Miss
Right,
Andrew,
evals, yes.
The YMCA should be logged on this tool, correct, and not
correct.
The 47 tool. Okay.
Yes. Hold on, here we go. Okay, so this was the first half through week 8 and midterm evals. People are good. You feel, how many hours should we be at, not counting B tests? I'm getting there. Let me get through the weeks and then I'll tell you. Because I can't really take VTAS out of the equation, but we will compare and contrast what students have, Vanessa. Okay, and then we moved on to the second half of the semester, right? Weeks 9 through 16. And this is when we started to incorporate YMCA in week 9, and then in week 10, the Ridge. So again, same thing. If you are at SVMH, then that's however many hours, pre, post conference, whatever, Clinica de Salud, including pre and post conference. And then if you're at the YMCA, then that's your 4 hours that you are at the YMCA. And then as we move into week 10, again, the same thing. The Ridge, probably 6, I'm thinking 6.5 hours, depending. I try to get us out at 1, but it just doesn't happen because of those noon BGs and insulins. But that's okay, because it's an extra 15 minutes or whatever, right? And so that's what you're going to do, incorporate those hours. And then as we keep going, right? And then week 12, which is, look at all that we've done so far, woo! And then now we're on week 12. We are so close. And so we have the holiday, so nothing gets written there. And then again, your SVMH or Ridge hours, the Y did not take students this week. No, yes, they did, just not on the schedule. My bad. And then you should just follow it through, right? Does that make sense? And then I'll get to week 16 in a second. You count you count the pre and post conference for the Y, although we didn't really, I don't think, do much of a post conference, but we do the pre-conference. You could, I'm thinking for Clinica and the Y, you could count up to 2 hours for the assignments that go with them. And then the time going and get a COVID testing, I mean, I guess because you have to do it, right? It's, to me, it's considered part of clinical, not your travel time, but maybe the 15 minutes that you're there getting tested, because some of you get tested more frequently than others. Okay. How are people following along with that? Does that help? And we'll do totals here in a second. I want to find one document to show you. And
so just to make sure, those days that we went to Clinica de Salud, you know how we did the debrief? So you're saying we could count 2 more hours on, like, say, the Wednesday of each week?
Well, the Wednesday
That
we do the post-conference. So if you wanted to take an hour for, like, I don't know how long it took you to do the assignments, right? And
Okay, so
so I'm trying to build in some time because to me, that's, if you were at the hospital or the Ridge, you would be working on that there. But you guys don't really do that because you're go, go, go in the clinic, right? Because it's just like constant.
yeah. So overall 2 hours, like 1 hour a week to do. each assignment.
Probably,
Okay.
I would
Okay.
say, to account for
I
the
just wanna make sure.
assignments. I would be okay
Yeah,
with that, but mark it as such on the comportment tool.
Okay, thank you.
Yeah. Why is it not? Hold on. There we go. Is that the one I want? Ooh, this is the one I want. Okay. So so VITAS, by the end of week 16, you should have 35 to 40 hours, hopefully. All right, hold that thought though. Let me show you something. So this I actually just found out this morning while we were in our planning and evaluation meeting. Do you see, it kind of looks like a grid sort of thing? Name of school, Hartnell College? Or is it my?
Yes,
ma'am.
Is it what?
We've got like bio 5, chem 20.
Yes. Okay. So if you keep going down to this bottom section here, this is where we are now. Okay. And so if you look at NRN 46, health promotion, and you follow it all the way over to lab hours, it's only 168 total. I thought it was 189. And I clarified with Ms. Cousineau today in our meetings that it is in fact 168. So that should bring a huge sigh of relief to some people. So that 168 includes VITAS as well as the clinical hours. Keeping in mind that we still have a couple more weeks to go. Right, 12, so we have 13, 14, 15. So we have 3 more weeks to go. Potentially week 16 if we're not even close, but anyway.
Is this document available to us to download?
I can post it for you.
That would be
that. Because it also shows you, because if you look now, if you look like this is the 2nd, 3rd, and 4th semester. So if you look, here's that 192. So that's closer to the 189. And then the total hours that you get are the 216, because that includes your skills.
And this is unlikely to change.
This will not change. This is the plan that has been submitted to the Board of Registered Nursing.
Will not change. Okay, I like it. Thank you.
And see, she signed it right there. This is from last week when the board was here, right? So, so I was mistaken. It's less hours in 46 because we have the hours in 110, which I've never counted before, but that's okay. And then you have your hours for social determinants, and then your the farm also counts, and then the what I want to say, the nursing assessment interventions course. So for 46, we're shooting for a total of 168. I don't know where that puts people right now, but from what was, are you, okay, hold on, going back to the chat here. So 24 hours for NRN's 47. Yeah. So I'm going to talk about NRN 47. We'll do that next. Health, not all the health assess, only those 2 health assess that I gave you in week 2 and 3. Because the other health assess just comes, you have the 48 hours for 48, because that's the 3 hours per week times 16 weeks. So you don't need to count health assess under 48. And you do not have social determinants next semester. This here is first semester, here is second semester. So second semester this is your theory clinical, the stable conditions. This is your skills course, which will now be interventions and scenarios. And then this is your pharmacology across the lifespan, which is, I thought it was 9 hours. It says 8 hours, 9 hours online. There's no lab component to that. So those are the 3 courses for, yeah, I have no idea, Emily. I wish I knew. Trust me, we have all been asking the same question. As far as so SBMH is telling us that we have to keep with the 4 student think like we've been doing in the clinical groups. Natividad has been taking our full cohorts, but they have a new director of nursing education, and we can't really figure out what she wants to do. She hasn't really told us how she wants to proceed. So unfortunately, so you have a couple scenarios. You have where second semester is at SVMH and 4th semester is at Natividad. You have 4th semester at SVMH and 2nd semester at Natividad. You have us all at Natividad. No, your community project does not end this semester. Your community project will move into the theory clinical course. We started in the social determinants, and then it carries through in the other ones.
So would you suggest that even though we don't have the times for our classes right now, it's my understanding that we're staying in the same cohorts, at least for next semester?
I don't know that, because what the dean has said, and I believe the dean has told several students this as well, is that y'all just sign up and then those become your new cohorts.
I thought I remembered you saying that we would be.
I did, and then the dean said no. I mean, she didn't say no. She said, no, it's whatever you sign up for.
Yeah.
But you would keep your same groups for the community project, but that kind of then people are mixing it up. So
yeah, because we have to go in person together to go do interviewing.
Correct. So it could be, what I'm envisioning is that you could sign up. Like, I don't even know who the clinical, I mean, I kind of think I know who the clinical instructors are, but I don't know if it's AMs or PMs, because I don't even know if we're at SVMH or Natividad. Like things, I've not been told anything. We're keep being told we're going to get that information, but it's up to the hospital, and they haven't really, Natividad hasn't really said anything. So what I'm envisioning
to sign up in our cohorts as it is.
You don't. So here's the thing. Not necessarily, because how are you going to know which one is which? What I envision happening is y'all sign up you sign up for your clinicals, but there's no instructor, there's no time, right? And so you don't really know what you're signing up for, but you have to register for something so that you get it in your schedule, correct?
Mm-hmm.
Is that my understanding? And so then what I see happening is the first week of school is that once I get the lists of who is, because I'll be coordinating second semester as well, for what it's worth, when I get those lists, then, and by then hopefully we'll know, what days, or days, Tuesday, Wednesday, but what times. We'll also know what community partners, that, community things that we can do to fit into the schedule as well. But I see us saying, okay, who's going to be, are we going to do the core, like we can move students around. That's not a problem, in my opinion, because we've done it. We did it for the current cohorts.
Right.
We've done it several years in a row. So I wouldn't necessarily stress. I know there's some people that may or may not want to be in the same cohort. And I know there's several people or more that either are going to start working or stop working or have daycare issues, so it depends if it's a day shift or a PM shift. Historically, we have not done PM shifts in second semester.
Mm-hmm.
But if second and fourth are both at Natividad, then somebody's going to have to do PMs. So I'm not sure how that, in fourth semester, we'll have days and PMs. They've always had days and PMs because they have Sutliff and Groner who do PMs, and then whoever they have for Denise, Miss Diamond, and I don't know who will be doing the other med surge. It could be Miss Pincus. I'm not sure. So I understand you're like, it's kind of like wait and see, because we can move people if that helps. I don't know if that helps or not, but that's the best I can do right now.
So would you encourage us to sign up for a section right now? Like any section, but then we know we can change later?
Unless the dean or Belinda said don't sign up. Because I know when you guys were signing up for first semester, didn't it take like forever because they kept saying wait, 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 and then you signed up, if I recall correctly?
They kind of were saying wait from what I recall as well, but we all ended up getting like moved around. Like they just went in and did it for us or whatever. So
yes.
I mean, basically kind of what I was told was like, well, you're in the program already. So it's not like these classes are going to run out of space. So it doesn't matter if we wait.
Correct. That's true. That is true.
I mean, unless you're like worried, okay, I need to budget for this. I need to see how much money I need to pay for my classes. Or
well,
what.
for some people, it could be the PM versus the AM because of childcare or work or whatever. Registration is open. I don't know which groups are able to go right now because I know it like there's like the rolling registration thing. But if registration's open. Are we at where everybody can now? Okay. Yeah, and I think when you register, you can't just register for 56, right? You have to do 56, 57, and 58. So, right, because it comes as a little package deal. And then as far as I know, we'll probably run 56, which would be your theory clinical course, will run pretty much the same way that we're running it now. We will try to do as much synchronous as possible. But there could be those asynchronous days. I'm not sure about Pharm. I believe Miss Diamond is teaching that. Don't quote me on that. And so I think she kind of likes to do face-to-face kind of type things. And then I don't know who's teaching skills, the nursing interventions. So I'm not sure the scheduling on that.
Ms. Sullinger, can I ask a question that you have the right to decline if you don't want to answer?
Since you put it that way.
I'm gonna allow you that one. No, I'm just kidding. So there's been some talk about the potential for classes next semester to be mandatory attended classes, not this whole asynchronous and being recorded and you can watch the video later sort of thing. Do you know if the nursing program has any plans on doing anything like that, or if they are still going to keep it recorded and available for others? And again, if you don't know, then whatever. But
I don't specifically know. What I do know is that our goal is for you to be on campus as much as possible. So that has nothing to do with 56. That has to do with 57, which is your interventions and scenarios or your skills course, right? And so the plan for that would be, I think it's still on Thursdays. I haven't looked at the schedule. I think it's still on Thursdays. That would be mandatory because that's skills, right? And so we want you on campus. You've asked to be on campus. I don't know what that schedule looks like. I don't know what you guys have signed up for in pause, but the expectation for that is if we're offering it on campus, you better be there. I don't know as we would specifically do 56 that way. I don't think it's an all or none, right? I think we can choose.
After talking to a faculty member that was involved in that discussion, she's part of the bio group, but she was telling me that the way it was presented to them is right now there is no option. You have to record the sessions that you guys do and offer them to the students, and it does not have to be mandatorily attended online. But
that is asynchronous teaching, yes.
But that next semester you have the option to make it synchronous, where they have to be, say it's a 9 to 11 on Monday, they have to be on Zoom from 9 to 11 on Monday. Otherwise, you can technically mark them as absent and drop them after a certain amount of times. And so that's where I was just wondering if for the online portion, if you guys had, any ideas as to whether you guys are going to be doing that or not, because I know there was
That's what I'm saying is for skills, probably like we haven't met as a group to plan for next semester yet. So that's why I'm saying is that clinical, obviously you have to be there. And then skills, I think would more than likely be made mandatory. I don't think the plan at this point right now is to make 56 mandatory.
Okay.
I don't
Yeah,
think
that- okay.
I don't think we have to make all three the same thing. I could be wrong. But there
No,
is
you have the option to do whatever you want with each class. I think that was kind of the idea there, was because there were some
I think so.
there were some teachers that were upset that they could not make a class mandatory. And so I think that's where the change was coming from. So you guys have the option. So that's why I was just wondering.
Yeah,
you guys were leaning a certain
my understanding was that we have the option to do that.
Exactly.
I don't, again, so I think I've answered that 3 times now. I just have nothing to confirm because I haven't met with faculty and I don't even know what I'm teaching really. So,
Sounds good.
But we did just get something through Senate. There was an email circulating that was talking about not nursing and allied health, but another division was talking about being totally asynchronous. So they may, as a division or program, have decided that their courses are going to be all asynchronous. But I'm waiting to hear back, if that applies to nursing and allied health. My understanding is it doesn't.
Cool. Okay, thank you.
So, okay. So 47, are we good with 46? People kind of figured that out?
Ms. Solinger, I have a good question.
Yes, Addie.
For 46, can we add, there's a worksheet for SBMH that we have to complete pretty much every single day we go in for each patient, for every week, every week that we go in, we have to complete a worksheet for SBMH.
Yeah, that would not count.
That will not count? Okay.
That would not count because you guys have the opportunity to work on that at clinical, but for like the YMCA people, as for out community rotations, there's not really time built into itself to do that. And so that's why I'm saying for the out rotations, the community experiences that you could take up to 1 hour per week to add to that. You would for SDMH count your post-conference time or pre-conference for sure.
We are expected to be filling that form in clinicals?
Yeah, I mean, yes
Okay.
and no. I mean, if you have the time to do it.
Okay.
I mean, that's always been my understanding. Now, the Ridge probably not because I have you going. That's not my point is paperwork. My point is doing. Kelly, I'm sorry, you had a question?
Sorry, no, I was kind of trying to help answer Addie. I think it's my understanding that whether or not we do paperwork during clinicals at the hospital depends on our clinical instructor. So our clinical instructor wants ours turned in by conference that day. So I believe that it's different for other clinical instructors.
Yeah. Okay. Got it. Perfect. Thanks.
Yeah, I believe you're correct. What else on 46?
Mrs. S, I
Yes,
have a
Buena.
question on the Vitas hours. For that 40 hours, is that included the post-conference that we're having every
Yes.
Thursday?
Mm-hmm.
Okay, thank you.
What else for 46?
Okay, so I have a weird thing that again is my fault because I don't think I recorded my stuff down correctly. So for all the way back at week 1 and 2, I've got the 4 hours at SVMH for the orientation. I then have, I have another 4 hours for health stream on 8/27.
Mm-hmm.
And for some unknown reason, I also have that on 8/31, but I don't, did we go 3 times?
I did.
Yeah,
Yes,
I
I
have
did.
the same.
It depends, yeah.
Okay. Okay.
I believe you had it available to you to go.
Okay.
And some people were able to get it done quicker than others.
Mm-hmm.
And so they may have taken probably week 1, you took the whole time, but the week 2,
Oh, okay.
You may have finished early, so you may not have, yeah.
Okay, thank you.
You may not have the same hours. Yeah.
Perfect.
Mm-hmm. Okay, anything else on, is this helping? Everybody kind of getting it figured out now?
Yes, my group already kind of did this together, but we had some kind of like, oh, well, this is different for us. Why? So I think this is helpful for us too.
Yeah.
This is helping tremendously.
Okay, cool.
Thank you.
Can I move to 47 or is there more on 46?
Sorry, what? Final question for 46.
Yeah, no, that's what I'm asking. Yeah.
Anything that is done through YMCA can count towards VTAS, like the assignments and the orientation and everything.
It doesn't count for VTAS, it counts for clinical. So like the MH column?
Mm-hmm. But the YMCA was used to supplement VTAS hours.
Oh, yeah, gotcha.
So,
you know, that's a good question. I think the commitment to VTAS is that we do at least 35 hours. However, because it was such, for lack of a better term, a mess for some students I think really got a lot out of it and it ran smoothly and, you know, it was okay. But there were several of you who really struggled. It just didn't click. It did for whatever reason. It's not your fault. I don't know who, like, I'm not blaming anybody. It is what it is. New program lists. I think personally what happened is VTAS got overwhelmed at some point. And then unfortunately the students, you guys got lost in the shuffle. But so the hope would be to get to that 35 to 40. But the reason that we gave you the YMCA is because some of you were not behind, but, you know, behind, not in a bad sense behind, just behind. So I think maybe, yes, maybe the YMCA hours should go under the VTAS column as YMCA. And then we'll see where we get, like you may not get to the 35.
yeah, because I also volunteered to take over a YMCA shift for somebody tomorrow, but that was usually my VTAS shift.
Right, and so that's, I'm thinking that's a good question. So probably VTAS, we can put those hours on, put the YMCA hours under VTAS, but mark it as YMCA.
Okay, thank you.
It will all come together at the end. It'll all come to that 168 total.
Yeah, well, I just wanted to make sure I was close to the 35 or 40 for VTAS specifically.
Right.
Thank you.
I don't know about VTAS next semester. I'm guessing students would say they didn't want to ever hear about it again, but I could be wrong. Like I said, some students had a really good experience, are having a good experience, and other students really are struggling with it. There is another part of VTAS where you can sit with the nurse on phone calls or do something like that. And so we're looking at that for second semester because that might be a little more conducive to learning, where you're actually sitting with the nurse, or not sitting with, but virtually sitting with the nurse, doing phone calls, doing telehealth phone calls or FaceTiming, Zoom kind of thing. But I'm not sure. So what that would do is you would have to figure out when, I don't know specifically, again, Ms. Clark is coordinating that, but my guess would be we would do it like we do any other thing. You'd be sort of assigned whatever caseworker or nurse that was, and then you figure out what time she's making certain appointments, and then you can look at your schedule and then figure out which telehealth phone calls they can make. Again, if we're at SVMH, you'll have a Tuesday or Wednesday that you could work with that person. If we're at Natividad, then you'd probably have to find some other times. I don't know if we're doing it for sure next semester, but that's what I've heard might happen. All right, moving on to 47. Remember, let's see. So for 47, let me go your food bank hours count, right? So let's go back. Let's go week by week. I don't have this on a schedule, sorry. So week 2, I believe you guys were working on your that planning document, right, for your community project? Somebody help me out here. Yes,
Yeah.
no, maybe?
Yes.
Okay, and so whatever amount of hours that was, identify that as such on your, on the tracking, the hour tracking tool for 47. I don't know if it was 1 hour, 2 hours, you know, whatever that was, right? Because that was that and that was that. And then week 3, so you guys, I'm sorry.
Just to make sure, so weeks 1 and 2, we don't track lab hours then?
So week 1 was ACE week. So
sorry, week 2 and 3?
So that's what I'm just saying. Week 2, you spent some time, I think, with your, hold on one second. Mr. Beamer's trying to get a hold of me. Miss SB. Hey, I'm in class. Can I call you back? Okay, no worries. No, we're just doing a Q&A kind of thing. So figuring out our clinical hours. I'll call you back. Thank you, bye. Okay, so week 2, that was your community project group planning.
That was like our first meeting, right?
Yeah, yeah, like that first, so that would be week 2. I don't know if you guys actually met. I don't know what the time frame on that was, because it was due September 11th, which would, yeah, so it may have been week 3 that you did that. But whatever hours it took your group to complete that document counts as lab time. Lab for this course is generally speaking an hour and a half. And then week 3, you had the discussion, but that doesn't count as lab time. That was just your assignment. And then week 4, I should probably go to your view, not my view, huh? Let's do that. Oops.
Yeah, week 4, I think we started food bank because I think I was there.
I think so. So let me go through the modules here. Yeah, because we would have started clinical. So I'm not sure if we had it set up by then, but yeah. So, and you guys should have probably done 2 food banks. I think is the goal 2 food bank experiences, I think.
Yeah.
Okay.
I've only done 1 so far. There's going to be more, I believe.
Okay, so food bank, and then which is what, like an hour, maybe 2 hours, depending, because you guys get there a little bit early, and yeah. And then you also, those of you that went to the flu clinics, right? Flu clinics count for 47.
Yeah.
And we're trying to find more.
Immunizations and the COVID testing.
Yeah, the COVID testing stuff, yes.
So real quick, the labs for this class, the few times that we kind of had lab classes, those count on this, is that correct?
Yes.
Okay, just making sure.
So that's why I'm trying to go through the weeks and figure out what that time was. Okay. And then I'm gonna say before teaching techniques. Oh, and by the way, your teaching techniques things were awesome. People did videos and all kinds. You guys did a really nice job with those, by the way. I think I graded all of them by now.
Did anybody else do a voice recorded commercial?
Yes,
Okay.
Several people did. You were not the only one. And so the assignment that you did on reflecting, right, for your how you were going to actually do your cultural and family assessment, right? However long it took you to complete this assignment counts as lab hours, because this is part of preparing you for what was supposed to be a home visit, right? And so this was prep work leading up to that. So if it took you an hour or 2 hours, hopefully it didn't take more than that. And I think I have all those graded.
Is the flyer something we can put on there for hours?
The what? The what?
teaching flyers?
No, I don't think so. No. But having said that, when you actually did your cultural and or family assessment, that time would count. So that's going to double dip on those of you that did your, that did it during food bank. But I know there's people, and then people probably did it as well in the hospital setting. So I just want to see where people come up with hours, and then we can work with that. What do we do week 6? Wish I could, oh, no lab this week. Okay, so this is, you'll see notes like this. There's no lab in week 6, but you get credit for doing the cultural assessment. So that's why there wasn't lab every week, right? Because it took you time to prepare or to make an appointment or to figure out how you were going to do it. Does that make sense? Probably didn't explain that very well. So apologies there.
So on our worksheet to fill out, it says week, date and time, description, and then number of hours. So like if I wrote down, because I hadn't printed out this tool yet, if I wrote down an amount of hours, but not necessarily a time frame, should I just leave time? Like I know what date it was, but I don't know what times it was. Should I just leave that blank, or should I like make up a time?
Well, as long as you have like, 1 or 2 hours.
Yeah.
But you don't need like 8 a.m. to 10 a.m.
Okay.
I don't think.
Okay.
Necessarily.
Okay.
Also, do you want us to just put like lab hours 1.5 hours, or do you want us to like specifically describe what lesson it was that week?
What the topic was. So I'm trying to think. So there's supposed to be one more. There's supposed to be one more home visit about the safety and fall assessment, but I'm thinking we could potentially use any time that you've used the fall risk assessment. I'm still trying to figure that one out. I want to see where you guys are on hours. Because from what I saw Ms. Groner's group's hours and Ms. Sutliff's group's hours, and most people were at or over the 24, or at least oops, sorry. Right, so I'm trying to, because if you don't have to come up with another one, I don't want to give you more work, in other words, is what I'm saying for the fall assessments. That's why I want to see where you guys are on your hours. And then you also have credit given for the times that you have gone into the community and done your assessments, right? So anytime anybody's gone into the community or done some work or meetings that you've had, then that counts as well. And then the immunization activity, which I didn't realize you can, you can print out a certificate, but apparently Claudia figured out how to do it. But it's pretty time intensive. So anything with, sorry, everybody's like texting me at the same time. The instructors, not you guys. So anytime that you spent doing the, going to the web-based training course, right? So log hours on your comportment tool for that. So I don't know how long. I was figuring about 2 to 3 hours.
Ms. Solinger, in on the canvas it says 3 hours that you put max, but honestly, after doing it and troubleshooting and everything, the first assignment took me around 2.5 hours. Just the first one, the medication administration. Can we claim it as 2.5 for that one? And then the other one took me 2 hours because it has videos.
Yeah, it says
and
at
also
least. It says at least. So yes,
Oh,
whatever. It,
oh, okay.
yes,
Oh,
at
oh,
least 3
perfect.
hours.
Okay.
Yes.
Oh, perfect.
Please take credit for all of that.
Thank you.
Trying to get you some hours here while learning something at the same time. So how many hours do people have ish?
I have almost 20.
Okay.
And I still have to, we still have work to do on the group project. So I'm thinking that that's going to get me there.
So you only need four more basically.
Yeah. And the 8-page writing is going to take longer than that. So
so hold on. Hold on 1 second, Claudia. So for the group project, it's not the writing of the paper. It's the being in the community and the planning for being in the community, but not the actual writing of the paper.
Okay. So if we all met up and we were all working together, that still wouldn't count.
I mean, yeah, generally speaking, when you meet, you're like planning for stuff, unless you're doing the, no, we're all sitting here working, staring at the screen together. But I think since you only need the 24 hours, you probably will be okay. I'm looking to see what's coming up here. So, well, it's as far as I go. All right, let me get out of there. Let me look at, hold on. Let me go to my other jump drive and zip drive, thumb drive, jump. What is the correct term, Hugo? Thumb drive, jump drive? Or do we lose?
Jump drive.
Jump drive? All right, let me look at one thing here and, 47. And I'm wondering, no, I think that counts for the finals week. Okay, so you can use your oral report time that you're giving. You can use that as lab time when you give your oral presentations for your community projects. Hello? Yes? No?
Okay.
Yeah. So, yeah. So I would say planning and or actually presenting your oral, because you're only going to have probably up to 15 minutes to do your oral report or your, telling us about your project, but you're going to probably put it at least 30 minutes or more into planning how you're going to do it so that everybody participates and figures all that out. So that will be some more time. And hold on 1 second. Let me find, there we go. I'm trying to find the weeks ahead here. And then, so week 13 is credit for your windshield. And week 12. Week 12 was your immunization modules. So that should take some time there. So it's 12, and then let me check and see. Week 13. Week 13 is also community project time. Right, so week 12 is the immunization modules you did. 13 is windshield. 15 and 15, 14 and no, I just lost 14. Sorry, hold on.
Is 13 the oral presentation? Is week 13? Is that when?
That's actually week 16. Because we do that in week 16.
Mm-hmm.
So that would be that. Yeah, week 14. I knew, I was like, what are we doing week 14? It's Thanksgiving. We don't have class week 14. Ah. There we go. So week 13 and 15 are windshield survey community project hours. Week 16 is your oral presentation and prep for the oral presentation.
But on the paper, we don't have week 16.
Yeah, we don't have 16 on there.
That end at 15.
Oh, well, add 16 then. I don't know about the birth control PowerPoint. Let me check on that for a second. What, yeah, just add or write in week 16 or something. I didn't realize when I put it down there that week 16 was that my bad, sorry. Okay. All right, that's 11. Hold on, I'm checking. I gotta look at my, oh, 10. Was that week 10 for the birth control stuff? Or week 9? Week 9.
9.
9? Okay, so week 9 is the one I'm trying to figure out about the fall safety assessment. Because if we have enough lab time, then we can, what we might be able to do is use the time. So, you know, for your assignment right now where you have to do the mini cog, or where you did, there was one assignment where you're supposed to actually do a fall risk assessment, like a Morris or Henrik on a patient. Like we could use that as lab time. So let me think about, because normally that would be a home visit. You would go into the home, do a visit. And I think what Ms. Clark and I talked about was where you could actually just do like a FaceTime or Zoom with somebody or in your own home and do sort of a safety assessment of the home. So I'll go back and look at that. But it sounds like people are pretty close to the hours. Because I'm seeing 21s and 20s, 21. I did not see, I believe the birth control PowerPoint was for lecture, not for lab. Okay.
So go ahead and remove that birth control one. I have it on here.
Is it, I didn't, let me look again. That was week 9, right? Maybe it was week 8 because I don't have it on, oops. Sorry. Oh, maybe because I'm looking at the wrong one. That would do it. 8. Oh, interesting. So for lab, it says, yeah, the student presentations were part of lecture, not lab. Now, if you're at Clinica I said, well, not everybody necessarily has that, because the lab for that week was counseling regarding contraception or STIs in a community setting. So that could be in the hospital, but you're probably not seeing that. Clínica de Salud's probably the best place to see that. So that gives us two options. The birth control project was, or presentation was lecture, not lab. So write that down.
How would you feel about us doing the family/cultural assessment on VITAS patients or caregivers?
So the thing, I'm not sure, because I think you have a script with them, right? And you're supposed to follow the script.
Yeah, I mean, unless they want to stay on the phone and they just want to chat, you know what I mean? Like, we're supposed to, like, oh, is there anything else? And if they're just like, well, I kind of just want somebody to talk to or whatever, we can hang out. So it's not necessarily just like okay, is there anything you need? No, okay, goodbye, you know, or whatever. If they're like, well, you know, I'm kind of feeling this way today or whatever.
I mean, I guess as long as you fulfilled whatever it is you're supposed to fulfill for VITAS, the problem is that when you're calling and speaking to them, you're representing VITAS, really. And so I just wouldn't want there to be confusion that it's VITAS asking them these questions.
That makes sense.
But I mean, if you get stuck and that's a last resort, I suppose.
Ms. Solinger?
Yes, Roberto.
I think so. Where'd it go? I only have about maybe 1 hour and a half for the first lab that we had for class. Can I just go down all the modules and for each week that actually had a lab, just add an hour and a half, or how would that work?
So I would double check with someone else in the class to see what they had. I kind of just went through the weeks.
No, that's fine. Okay, I'll just reach out.
And your food bank, and I don't know if the food bank hours and if like if you did flu or COVID clinics, because a lot of those were an all-day thing or a big chunk of hours. So if you didn't do one of those, then you know you might be a little bit low. But I would say, yeah, go through the weeks and then talk amongst your cohort and kind of see where people are, and then and know that we have a couple weeks left, that you're, you know, probably working on your community project. And I'm going to take a look at the fall risk assessment and see if we can somehow combine that for lab time, right? So that you're kind of killing two birds with one stone, either with the cognitive assessment or the fall risk, because it's about safety. So it may be that when you do you actually do the assignment, even though it's in 46, we could count the time for 47 because you're actually assessing safety, right? When you're doing the mini cog, you're looking at cognition, right? Because then we wouldn't have to backtrack and do the fall risk. I'm trying to help you out here, kill two birds with one stone. But you guys are close. If you're at 21 hours or more, then you're good. Okay, what else is going on? Does that help? You guys feel like you're a little more together with that?
Yes.
Yeah, I did. Thank you.
Okay, so then what I would do is entertain keeping Amanda and Emily to talk about YMCA since we're all still here. And I would stop recording. Yes.